In this lecture, I'll be covering inpatient diabetes management and hyperglycemic emergencies. Here are the learning objectives along with recommended reading. I would also encourage you to review prior lectures regarding diabetes and glycemic emergencies. So you should know by now that hyperglycemia has pretty bad outcomes. It leads to increased inflammation, so think of patients that are admitted with an infection. Obviously, bacteria are just like any other organism. They require glucose for support, so you want to maintain their blood sugars as well controlled as you can. Hyperglycemia leads to neuron damage, especially following a stroke, so you want their blood sugar well controlled if they're admitted for a neurologic cause. It also increases the risk of thrombosis, free fatty acid overproduction, also free radicals, ketones, and lactic acidosis, which is what you see in DKA. Hypoglycemia has even worse outcomes. So the typical goal is if the patient's in critical care, you want their blood sugar a little bit higher at 140 to 180. That should be the goal. Whereas if they're not in a critical care, say a medical or progressive care, you want their pre-meal glucose less than 140 and random glucometers less than 180. So the first step in working up a patient with hyperglycemia is to know their home medications and specific doses. Now, a lot of times patients won't be able to tell you this, or they'll just be unsure. So this is when you have to contact their primary care physician. You may need to look at prior records to see what they were on in the past. A lot of EMR systems actually have databases in them where you can look up and see what medications they've had filled recently. Sometimes you may have to contact their pharmacy to see what was filled recently, just stuff like that. But it's imperative to always ask a patient, especially when they're first admitted, what medications they're actually taking in specific doses. Next is they need to be on a carbohydrate-controlled diet. So carbs are basically sugar. We know 1 gram of carbohydrate equals 4 calories, and carbs should make up around 45 to 65% of total calorie intake in a diabetic. So let's just round this to around 50%. So if a patient is on a 2,000 calorie diet, that should be approximately 1,000 calories per day should come straight from carbohydrates. So if you take 1,000 divided by 4, that equals about 250 grams of carbs. So most common carb count diets in the hospital are anywhere from 180 to 225. We really don't want to give them that much sugar. So that's just something to keep in the back of your mind. They should also have glucometers with meals and at nighttime. And then hemoglobin A1C is imperative to get, especially if they haven't had it within 90 days. You can see from the left-hand side that, I'm sure you already know this, but a normal A1C is less than 5.7%. Anything from 5.7 to 6.5 is considered diabetic. Typically anything above 9 or so is when you start getting a diabetic educator on board, and then anything above 9 or 10, they're pretty much that they're going to be insulin dependent, because an oral hypoglycemic agent isn't going to drop them enough to actually make their A1C around 7, which is your goal. So as mentioned, the hemoglobin A1C will help establish, or I hadn't mentioned, but an A1C will help establish compliance. So if a patient, says, I take my medications regularly, but then you see that their hemoglobin A1C is 13, either they're not taking their medication compliantly or their diet is terribly non-compliant. It also distinguishes diabetes from stress hyperglycemia. So if you see that their blood sugars are 200 in the hospital, but their A1C is 5 or 6, then you know that it's probably a stress reaction like an infection or inflammation that's causing their blood sugar to increase. It also helps in discharge planning, as mentioned earlier, where if their A1C is above 10, then you can help justify to them the importance of starting insulin. A lot of type 2 diabetics are on OHAs when they come to the hospital, but then when they get discharged, they go home on insulin, and this helps justify that. So this is where diabetes education plays an important role, and this is something that you can do along with other providers. A lot of hospitals, I know my hospital, they actually have diabetic educators that come around and talk to every single patient with an elevated A1C above 9. As far as treatment goes for diabetes, we know there's basically 3 options. There's oral hypoglycemic agents. These are just the oral pills that you take for diabetes. There's insulin as a drip, and insulin that you can give sub-Q. And I'll talk about these in a little bit. There are lots of different types of oral hypoglycemic agents. For instance, metformin, this is a biguanide, decreases hepatic glucose production and intestinal glucose absorption. It's important, though, to understand the side effects. So it causes lactic acidosis, can cause contrast-induced nephropathy. There's sulfonylureas such as Amaryl, glucotrol, glipizide. These can cause unpredictable hypoglycemia, especially in a patient admitted to the hospital who has underlying inflammatory or infectious condition, and we know that they're not going to be eating predictably or their appetite's decreased at certain times, so sulfonylureas really aren't a good choice. Thiazolidinediones, such as Actos and Avandia, really aren't used much anymore. They tend to cause a lot of fluid retention, which can lead to heart failure and volume overload, and they can cause cardiac ischemia. GLP-1 agonists such as Victoza, Trulicity, Byetta. These medications are a little newer, but they can also cause nausea, vomiting, diarrhea, which is the last thing you want in a hospitalized patient. They also increase the risk of upper respiratory infections. They can cause headaches. And then you've got alpha glucosidase inhibitors, like acarbose. These cause GI upset, just like GLP-1 inhibitors. GLP-1 agonists. They can also increase LFTs. And then you've got DPP-4 inhibitors such as Januvia, Tradjenta, and Glyza. These can cause pancreatitis, also can cause GI upset such as nausea, vomiting, and diarrhea, and flu-like symptoms. And then you've got meglitinides such as Prandin and Starlix, which are rarely ever used anymore. And then also SGLT2 inhibitors such as Invokana, Farxiga, and Jardiance. These basically cause you to pee out glucose, so it's going to increase your risk of urinary tract infections. It can cause thrush, it can cause your potassium to increase, and can cause hypoglycemia. So I don't expect you to remember every single detail about all the different OHAs. However, I want you to understand that OHAs in the hospital, you typically just hold these. Unless the patient's there overnight or their observation or they're here for something that's very minor, where you expect their appetite to be the same and you don't expect any problems overnight. You don't predict that they might need any kind of CT imaging that would require contrast. It's just safer just to hold these while they're inpatient and just give the patient insulin. And then they can resume the OHA once they're discharged. The majority of patients that are admitted to the hospital are managed with sub-Q insulin. There's basically 3 types. You can give basal insulin. This is long-acting insulin. You can give bolus insulin, which is mealtime or nutritional insulin. And then you can give correctional insulin. This is sliding scale insulin, which is rapid-acting insulin. It's only used to lower the blood glucose immediately. But as you can see from this graph, if you just use correctional insulin alone, you're going to get lots of spikes. You're going to have the blood sugar constantly up and down, so you're really not going to control them very well. So it's been proven over and over that the basal bolus method is by far the most effective way to manage inpatients. The basal bolus method basically just means that you're going to give a long-acting insulin with a short-acting insulin with meals. So, whether the long-acting insulin you give at night or in the morning, that's dependent on what the patient was on before they came in, what their glucometers are doing, when their blood sugars are high, when they're low, stuff like that. And I'll talk about that here in just a little bit. As far as long-acting insulins go, there are several different types, and you can see from this graph how effective they are in the average times. So NPH is one of those long-acting insulins that you give twice a day. I know several physicians that prefer this medication while the patient's in the hospital just because it's much easier to titrate. You've basically got two chances throughout their 24-hour period to adjust up or down on their NPH, whereas if you give Lantus or Levemir, it lasts so much longer, so you really can't give them extra doses. You can, but then you take a big risk on causing hypoglycemia later on. And then there's regular insulin, which is kind of middle of the road, but it doesn't last for like a full 12 hours. So, it lasts a little over a full 12 hours. So, usually the patient will gradually build up they'll gradually build up their insulin response, and then all of a sudden they'll drop with that insulin. That can also happen with NPH, but it's not quite as common with that one. And then you've got your rapid-acting insulins, such as Humalog, Novolog, or Pedra. So just to break down basal bolus regimen a little bit further. So if the patient is a known diabetic, the first step is you want to calculate their total daily dose of insulin. This is where you add up all of the patient's home insulin, whether it's, basal, bolus, whether they're on Levemir, NPH, whatever. You just add up all of the units that they're on and take that total. Then you take 50% of that and make it basal, and 50% of that and make it bolus. So then you add sliding scale coverage on top of that. Sliding scales typically come as type 1, type 2, or insulin resistant. So, think of like a type 1 diabetic. These patients are typically, they're not resistant at all to insulin. They are very, very sensitive to it. The problem is they just don't secrete it. So the doses of sliding scale are actually going to be a lot lower for a type 1 diabetic, whereas a type 2 will be in between, and then an insulin resistant, they're going to get a lot higher doses of bolus insulin with meals. So that's how you do for a known diabetic. Now, a new diabetic, to initiate the total daily dose, you basically just have to remember this calculation. It's usually 0.4 to 0.6 units per kilogram per day. So, if they weigh 50 kilograms, then, you determine what dose of insulin to give by calculating by 0.4 to 0.6. Now, how you decide that is dependent on what their sugars are running. So if it looks like they're really sensitive to insulin, then you would want to do the lower dose, so maybe 0.3 to 0.4. Whereas if their blood sugars are really high and they already got insulin in the emergency department and they really didn't change much, then you know that you need to use the higher amount. So then you'll take that calculation, you'll divide it out based on their kilogram, and that will give you their total daily dose. And then you take that, 50% of it as basal, 50% of it as bolus, and then you add sliding scale on top of it. Here's an example to further break this down. So you've got a 65-year-old male who presents to the hospital with chest pain and is admitted for ACS rule-out. Patient's blood sugar is 205, so not terrible. A carb count diet has been started, And patient's home insulin regimen includes Lantus 50 units sub-Q QHS along with metformin 1,000 milligrams POBID. His A1C per the medical record 2 months ago was 8.8%. So you know that his blood sugar isn't controlled the best. You know that if he's coming into the hospital, he's got something acutely inflammatory. He's got, we're ruling out acute coronary syndrome. So we would definitely not want to continue the metformin, mainly because we don't know if the guy, maybe he'll develop worsening chest pain and hypoxia, and we'll have to get a CTA of his chest. So then we'd have to give him contrast, and we take a chance on causing lactic acidosis with adding metformin. So that's what I had mentioned. It's always safer just to hold those OHAs when they're in the hospital. So for this patient, we know that his total daily insulin intake is 50 units. So it doesn't matter what kind, okay? But then basically we're going to take 50% of that, which would equal 25 units, and we're going to give that to him, either morning or night, whatever we decide based off, when he needs it. For instance, if he's coming in at 10 p.m. and his blood sugar's 300, I'd probably just want to go ahead and give the bolus or the basal dose at night. Whereas if he's coming, in the morning and his blood sugar wasn't too bad, then he can probably wait until that night. So yeah, that's for the 50% basal. And then for the bolus, that would include the other 50%. So that means you need to give 25 units in the bolus. However, that's divided into meals. So, that would equal roughly about 8 units with breakfast, with lunch, and with dinner to equal around 25 units. So then he'll get his total 50 units, and then we'll add correctional insulin on top of that. So he'll get sliding scale on top of that Lispro with meals. With this said, there are a few rules that you should remember when assessing their insulin need daily. So if their fasting blood sugar is 100 to 140 without any previous hypoglycemia in the past day, then you don't have to make any changes. Whereas if it's 140 to 180, and I'm talking just their fasting blood glucose, so this is more than likely that AM blood glucose. If that's 140 to 180 without any previous hypoglycemia, then you probably need to go up by 10%. Whereas if it's greater than 180, you need to go up by 20%. So if it's decreased between 70 and 100, you probably go down by 10%. And if it's less than 70, which is considered hypoglycemia, then you go down by 20%. You don't ever just hold the dose. You don't ever just hold their basal insulin. You just need to decrease the dose. Otherwise, they're just going to shoot way up. So back to that previous example. So here are some blood sugars, and as you can see, this patient's blood glucose is not well controlled, as you would actually like his pre-meal blood glucose to be less than 140, or you'd like his fasting blood glucose to be less than 140. So, at breakfast he's 267. At lunch he's 167, and dinner 192, and at night you can see it jumps up quite a bit, and that's when you give the Lantus dose. So you can see from this example, try to take a minute to look at this and see what you would change on this patient. So the way I look at this, you have 3 different options that you could actually adjust this patient's insulin. You could use the basal bolus method, which would, for this patient, since his AM glucose, his fasting glucose was 267, well above 180, you could definitely you could go up on his total daily dose by 20% and divide that dose by, his basal insulin and his bolus insulin. So therefore, if you went up by 20%, you'd, of the 50 units, you'd be giving another, 10 to 15 units. So you'd probably go up to maybe 32 units QHS on his Lantus, and then maybe up to 10 to 12 units with meals of his prandial insulin, and then continue a sliding scale. Another way that you could do this is just increasing their long-acting. So you could just go up on the long-acting. You could go up by 20%. So, just add the whole 10 to 15 units on top of that QHS Lantus and go up to 35 and see what happens the next day. It's really all trial and error and whatever your preceptor is the most confident with. There's really no right or wrong answer here. And then the final way that you could do this is just to increase their bolus insulin. This is a little riskier because if the patient doesn't eat the same carb count as the previous day, the blood glucose will be the exact same. So you risk overcorrecting and causing hypoglycemia, which is even more dangerous than hyperglycemia. Now I'll talk briefly about glycemic emergencies. So I'm sure you've probably had prior lectures in this, and I would urge you to go back and review those if you need a refresher on this. But DKA combines hyperglycemia with an anion gap metabolic acidosis, whereas HHS is hyperglycemia and hyperosmolarity. The key to understanding the difference between these is in HHS, typically this is type 2 diabetics, they are creating just enough insulin to prevent lipolysis, whereas in DKA, they're not. So they have no insulin. Their beta cells do not secrete any insulin, so they automatically have increased lipolysis, and that's what leads to free fatty acids, which leads to ketone bodies, which leads to ketoacidosis. You don't get that process in HHS because they have just enough insulin to prevent that. Therefore, they usually have really high blood sugars. It can be anywhere from 600 to 12 or 1300. I've seen even higher than that. But that is what creates the osmotic diuresis, which leads to dehydration and which causes the hyperosmolarity that you see in HHS. So I just wanted to rehash a few common questions that I've had in the past with glycemic emergencies. First, what is the difference between DK and HHS? Well, as I covered in the previous slide, remember, HHS, you produce just enough insulin to prevent lipolysis. Why is hyperglycemia lower in DK than HHS? Well, acidosis leads to earlier symptoms and thus an earlier presentation than HHS. Also, DK typically occurs in younger patients who have good kidneys that can filter out the glucose. HHS typically develops much slower, usually over 2 to 4 days, whereas DK can develop in the matter of hours. Why do you commonly see hyponatremia in glycemic emergencies? Well, hyponatremia is caused by a combination of salt loss by diuresis and poor PO intake. This is combined with transcellular fluid shifts as a consequence of hyperosmolarity. So calculated corrected sodium, remember that, how you calculate that. It's typically 1.6 per 100 of glucose. So if your blood sugar is 200, you need to correct for 100, so you would raise the sodium by 1.6. So the calculated corrected sodium is a prediction of what the sodium would be if the glucose was not high at all. So why do we actually care what the corrected sodium is? Well, because if it's low, it tells us something else is going on besides just the hyperglycemia. For instance, it could be heart failure, cirrhosis, SIADH, remember, nephrotic syndrome, something like that could be underlying, and then you need to treat the underlying condition correctly. Remember that you can cause central pontine myelinolysis if the sodium is corrected greater than 0.5 per hour or greater than 12 in a 24-hour period. You typically don't worry, though, about CPM initially when you're bolusing, or if there are any signs or symptoms of shock or severe dehydration in the patient. And finally, why does potassium drop when treating glycemic emergencies? Potassium drops during insulin treatment because correction of acidosis causes excess hydrogen that is built up intracellularly to be exchanged for potassium. Also, insulin directly stimulates potassium uptake by the cells. As far as the treatment of glycemic emergencies goes, it's important to understand IV fluids. So your typical DKA patient is down 3 to 6 liters, whereas your HHS patient is down 8 to 10 liters. So they need aggressive fluids given. You typically give 1 to 2 liters normal saline right at the beginning. So typically when the patient's in the ER, this is what the ER doctor's done. After that, you need to give maintenance fluid, and this is where you calculate that corrected sodium to find out if they've got an underlying physiology going on that you need to correct for first. So if the sodium is normal, then you give half normal saline at 250 to 500 mLs per hour. If the sodium is low, then you can typically stick with normal saline, and then you consider adding dextrose once the blood glucose is less than 200 in a DKA, or it's less than 300 in an HHS patient. Always when you're giving IV fluids, you need to monitor for fluid overload very frequently and teach the patient and family members about the signs and symptoms of fluid overload. As far as potassium goes, you never start insulin or an insulin drip until the potassium is greater than 3.3. I actually made this mistake once when I was working in the ER. I was a new grad PA and had a patient in DKA, and I started them immediately on an insulin drip, thought I was doing the right thing, and I didn't realize their potassium was like 3.1. I started the drip, and immediately the attending physician came down and checked on him and ordered a stat K, and it was down under like 1. So the patient started having arrhythmias and became more lethargic, and they had to go to critical care, and I felt terrible about it. So I just don't want to see you guys make that mistake. So typically if the potassium is less than 3.3, you need to replace it before you give insulin. Whereas if it's above that, then you typically just add potassium to it. Or to their IV fluids. If it's greater than 5.2, usually at that point you don't need to give any potassium in the IV fluid. Insulin drips are highly underutilized. They're typically used in DKA and HHS, however, they can also be used in uncontrolled diabetes. For instance, let's say you have a septic patient who comes in with a blood sugar of 400 or 500. You want their blood sugar well controlled, so it would probably be easier to put them on an insulin drip and get it under control, and then change them over to basal insulin after that. The thing is, it does require a lot of knowledge on the nurse's part, so it's typically better if they can go to a unit that specializes in managing these drips, as they can be very dangerous. And they typically require blood glucose monitors every hour. So there's lots of different protocols for insulin drips, and I don't expect you to memorize this, but a typical formula to remember is 100 mLs of normal saline plus 100 units of regular insulin is what actually makes up a bag of insulin. It typically gives 1 unit per ml. So you typically give a bolus of insulin followed by an infusion, and this is done by a general rule as their blood glucose divided by 100, and then this is rounded up to the nearest 0.5 unit. For example, you have a 23-year-old female with diabetes type 1 who presents to the ED with nausea, vomiting, and abdominal pain. Patient is found to have anion gap metabolic acidosis and a blood glucose of 511. You determine that the patient needs an insulin drip. So obviously this patient is in DKA. So what dose of insulin should you give? Well, so if their blood glucose is 511, you take that divided by 100, which equals 5.1, so you round that to 5. So you would give an insulin drip with 5 units as an IV bolus, followed by 5 units per hour. So when do you stop the drip? Well, there's several criteria for this, but you need to make sure that the patient is rehydrated, first of all. You need to make sure that their mental status is normal. You need to make sure that their anion gap is closed. You need to make sure that their acidosis has resolved, and also that their pH is fine. So their acidemia is fine also. You typically don't have to get a blood gas to tell this, but most of the time if they're serial BMPs, you're watching their anion gap and their acidosis, and these will correct on their own and the patient will feel better, and that's when you know that it's time to convert them over to insulin. However, don't forget that you need to start long-acting insulin 1 to 2 hours before shutting off the drip to prevent rebound hyperglycemia. I know that was a lot of information in a short amount of time, so if you have any questions or concerns, please post them on the Google document. Here are the sources I used for this lecture. Thank you.